Okay, I think we'll go ahead and get started. Bismillahir Rahmanir Rahim. With hamd and shukr and molani duasi, the Safi Burhani Medical Association America would like to welcome Dr. Mullah Mustafa Bhai Abdul Hussain. Originally from Sudbury, Ontario, that's in Canada, Dr. Abdul Hussain graduated with honors in biomedical biology from Laurentian University and then went on to earn his medical degree from Ross University. He worked as a junior instructor in the behavioral science department at Ross University, which led him to pursue a psychiatry residency at the University of North Dakota in Fargo. During his training, he also earned his MBA in North Dakota State University. Since graduating, he has worked in various settings, such as outpatient clinics, inpatient psychiatric units, nursing homes, consult liaison roles, emergency department and inpatient eating disorder units. He participated in the ethics committee for several years and supervised residents and students as a faculty attending. Currently, he is working at North Memorial Hospital in Minneapolis as a consult liaison psychiatrist, seeing patients admitted to hospital medicine and in the emergency department for higher acuity cases. In addition, he works at an interventional outpatient psychiatry clinic in Minneapolis treating depression-resistant patients with ketamine and transcranial magnetic stimulation. If that's not enough, Dr. Abdul Hussain specifically requested to hold the webinar at a time when his children were at madrasa, so it would not cut into his family time. What an inspiration for maintaining a good homework-life balance. Hopefully that will prevent some depression in his household. Dr. Abdul Hussain has previously presented a Depression 101 course at a previous Safi Burhani Medical Association conference in Chicago. We welcome back Dr. Abdul Hussain to present in our webinar series on Beyond Depression to give us an insight on treatments for depression-related resistant patients. If the audience has any questions, please post them in the YouTube chat and they will be addressed at the end of the presentation. Chalo shukriya. Welcome, Dr. Abdul Hussain. You have the virtual floor.
Thank you, Dalwa Ben, for that kind introduction. Bismillahirrahmanirrahim. Pehla Mola Talo Sharif na Hakma dua kariye ke je Mola SBMAA કાયમ કર્યું છે for મુમિનીના સેહત વાસ્તે. અને એમ બી જરા કહી દઉં કે મોલા તવલા શરીફ વારંવાર આપઘાત અને ડિપ્રેશન અને નાઉમી થવાનું વાઝ મુબારકમાં બયાનોમાં ફરમાવે છે. અને મોલા એમ બી ફરમાવે છે કે હુસૈનના ગમ સિવા કોઈ ગમ ના બતાવે. તો આપણે એમ બી દુઆ કરીએ. અને આપ સગલાને ખાસ મોલાની 80મી મિલાદ મુબારક મોહનના કરજો અને દુઆ કરીએ કે ખુદા તાલા આકા મોલા અમારા બાવાને મોલા જાનો સી ઓલા કયામના દિન લગ બાકી રાખે. Amin. I also want to thank the SBMA committee for inviting me. After my last presentation in Chicago, I wasn't sure if they'd ever invite me back for a talk, but I'm glad that they did. And I'd also like to thank the mental health working group, especially, and the webinar working group, Aziz Bhai Punawala and Dr. Amar Bhai, Tekum Bhai, and Mulwa Ben especially, who have really had tireless efforts and they've helped make today possible. So thank you so much. Okay, going on to Beyond Depression, strategies for treatment-resistant patients. First thing is that I have no disclosures. I do want to talk about ketamine, and it doesn't carry a indication yet, especially IV ketamine. So that will be an off-label use. And then I'm not giving advice to anybody. I'm not telling anybody how they should treat their patients. I'm not saying that if you are somebody struggling with any of these illnesses, that this is how you should present it. It should not replace the advice, from your regular doctor. This is just meant as informative and for educational purposes. So during the presentation today, what I'd like to do is start with a case discussion. And then we'll just review depression signs and symptoms. And then we always have to talk about suicide and self-harm risk when we're talking about depression. I do want to talk about sleep and depression because those often go hand in hand and they're kind of its own little thing. And then there's a lot of different providers on the meeting today, I think, from a lot of different specialties. I know, for example, Lula Ben's from pediatrics, but there's surgeons and oncologists. I would imagine hospitalists and internal medicine physicians. And so I'd like to really talk about medical illnesses and the crossover with depression. And then I think the bulk of the presentation, the time I'd like to spend is on the last 2 points here, the overview of the depression treatments and then medical illnesses. So the first 3 or 4 things we'll speed through a little bit quicker. So this is the case that I found, and it's a Nigerian woman. Her name is Rebecca. She's a practicing Christian. She's been talking to her priest about her fears of eternal damnation. He says that she has become obsessed with God's punishment and expresses concern that she has lost weight and does not appear to be sleeping. The priest advises her to see a doctor. So when Rebecca comes to see you, she appears low in mood and tells you that she is only here because her priest told her to come. Throughout her conversation with you, she thumbs through a well-worn Bible in her hands. So just wanted to discuss this, kind of get our mental health juices flowing, I guess. The initial groups of psychiatric symptoms, I think we're talking about treatment-resistant depression, so hopefully mood symptoms isn't a big shocker. But when we need to explore that a little bit further. So the only information we have right now is that she says that she's down, she's essentially depressed. But we would explore that further. And one of the important things you would ask is, does she have any diurnal variation in her mood? That would be important to know. So for example, does her mood get worse in the morning? Does it get worse, or does it improve throughout the day? That's usually indicative of depression. And then what is the progression over time? So is it just sudden? Is it happening right now? Has it been chronic? Those are important questions to know. There was a little flavor of psychotic symptoms with this, and so we'd need to explore that further. We'd need to ask her about delusions and hallucinations. Obviously, when it comes to religion, we'd need to know how she came about it. What's the context and how she's believing, especially her cultural context in what she's believing, and if those beliefs are shared by other people. So that would be important to know. In the case, all we know is that the priest is telling her to come in, but then the priest, the case specifically talks about how she's from Nigeria, so we don't know what the priest's cultural background is. So it'd be important to talk to her family and friends and people who know her and to see if what she's reporting is out of unusual for her. Obsessional symptoms, I think the case used the word obsessed. I think that's what the priest said, that she was obsessed about this. And so if we want to explore that further, we'd have to ask her how she feels about these thoughts, and if she feels that they are what we would call in psychiatry ego syntonic or ego dystonic. Do they make sense to her? Or is it something that she's not choosing to dwell on, or is something that she is choosing to dwell on? And then with that, of course, we want to know about any compulsive symptoms or actions that she has to do, hand washing, for example, prayers, repeated prayers, that sort of thing. Suicide risk with any patients with depression, that's very important to talk about. She's talking about God, she's talking about heaven and hell and that sort of thing. Does she want to hasten the process? Many times patients with very circumscribed religious beliefs, actually that is a protective factor for them. So initial workup, when we meet this patient in the first time in the clinic, if assuming they haven't been seen by primary care, or if I'm seeing them for the first time in the hospital, there are some initial investigations that we'd like to see done. Of course, routine lab work like a CBC or CMP, and then a urinalysis would be, just basics to start with. In some patients, I'd also like to see a urine toxicology screen, just to screen for any substances that may be affecting her mentation. There also is the possibility of organic or iatrogenic causes, which may be on our minds as well. And so we might want to do an X-ray, a chest X-ray, for example. If it's her first episode and this is out of unusual for her, then we may consider a CT head as well to rule out any bleeds or any masses, any other lesions. So assuming that we land on depression as the causative agent and the thing that she's struggling with, then we are going to likely prescribe medications for her. And so there are certain things that may cause different treatment responses for the same medication, but different patients. And the biological factors are family history, genetic factors, any previous psychiatric illnesses, any current physical illnesses, medical illnesses, and then substances. Those would all be biological factors that would affect the success of our treatment and may or may not lead to treatment resistance. Psychological factors are also very patient dependent. So does she have a history of loss? Does he have a history of trauma, any childhood maltreatment? That makes it more difficult to treat. And then any social effects, like poor social supports, if her finances are very precarious, if her living situation is precarious, you can see how as you add those things up, then somebody might become more and more treatment resistant, especially to first line interventions. So everybody, the assumption I'm working under is that the majority of the people on this call are medical professors or professionals or have some exposure to the definition of depression. But just a quick review. So the SADC synopsis of psychiatry defines mood as a pervasive, sustained emotion or feeling tone that influences a person's behavior and colors or perception of the being in the world. It's an old struggle that humans have had. There's been documentation of it in the Old Testament and Hippocrates, black bile, everybody, talks about that, the four humors, for example. And then now the definition that we work under, and this is from the DSM-5, is the major depressive disorder. It's an episodic disorder that lasts at least 2 weeks. And then there are 4 symptoms, which I'll talk about in the next slide. And one of those has to be at least, in addition to, so 5 total, in addition to decreased interest and low mood. Lifetime prevalence is approximately 10 to 20%. So out of 100 people, at least 10 people will experience one episode of major depression in their lifetime. And this is replicated, not just in the United States, but all over the world. It is more common in women than men, and that may be related to hormonal changes. It may be related to effects of childbirth and also different psychosocial stressors. In addition, and I think this is improving with time, but women, historically speaking, were thought to seek help more than men for mental illness-related struggles. So in that sense, it may have been diagnosed more, sort of a selection bias. Mean age of onset is still thought to be about 40 years of age, and but 50% of those cases are younger patients. Okay, so a brief note on etiology and what causes depression. So the biogenic amines, we're all familiar with those. Norepinephrine and serotonin are most often implicated, especially, and they are now the targets of and the majority of medications that we use. Dopamine also thought to play a role. Hormonal regulation is kind of interesting as well, especially from severe early stress. There's an increase in the hypothalamic pituitary adrenal axis. And so there's an increase in corticotropin releasing hormone, which then releases adrenocorticotropin releasing hormone, which then affects the adrenals. And then that releases more stress related hormones and affects how somebody's feeling. Alteration in sleep neurophysiology is also thought to play a part. And then on imaging, we see there are hyperintensities in the subcortical regions of the basal ganglia, thalamus, and then also decreased anterior in the frontal lobes metabolism. We talked about genetic factors briefly, and I believe it's chromosome 2 that is most robustly implicated with depressive risk. And then cognitive distortions, and those are altered by early experiences. Okay, so moving on. So how would you diagnose somebody with depression? And again, we're talking about major depression. The next couple of slides, I'll talk about some of the nuances of diagnoses, but this is pathognomonic of depression. I think everybody's familiar with the mnemonic of SIGI caps. I still sometimes refer to it when I'm teaching residents and medical students. So 5 or more of the following during the same 2-week period. It's not associated with any other medical illnesses, and it's causing significant distress in their lives and occupational functioning and their psychosocial experience in the world. Generally, sleep is decreased with early and late insomnia, But that is even though they want to sleep. So that's a big differentiating factor from, say, mania, where you can also have decrease in sleep, but you don't feel like you subjectively you feel refreshed and you feel good and you want to go in mania. Anhedonia, guilt, energy, concentration, weight loss, and appetite is affected, psychomotor changes, and of course the big one is suicide. As a medical practitioner, you might want to suspect somebody struggling with depression if they're not being forthcoming about it, if their mood or somatic symptoms are out of proportion to what you'd expect, they have a poor response to standard medical treatment, they have poor motivation to participate in treatment, or they're having a lack of engagement with care providers, apathetic essentially. So again, I know this may be a little bit more detailed than what most of you are thinking about, but it's important to know because if you're dealing with a treatment resistant case, then you really want to make sure that your diagnosis is not, you're not missing anything with the diagnoses, because obviously diagnoses affects treatment planning. So the different categories, there's 8 different categories just of depressive illnesses. And we always think about MDD as the only one, but there are quite a few others. So persistent depressive disorder is essentially low-level depression, but for a longer period of time. And that's important because PDD patients are actually harder to treat. It's not like a single episode of MDD and you prescribe an SSRI, for example, and they get better. PDD patients often need longer treatment. If the substance is pathophysiologically associated with inducing depression, i.e. alcohol or medications, for example, benzodiazepines can sometimes worsen depression. Theophylline for asthma can cause depression and worsen depression. Steroids, we'll talk about that in more detail as well, but those are associated with worsening mood. Again, this I've seen this used a little bit on the medical floors as well. So my colleagues in internal medicine will think about a patient with depression, and they're right. I mean, the patient is sad, so in that sense they're correct. But here, for just to call it this, as far as the DSM goes, again, it has to have some sort of physiological mechanism to cause the depression, rather than I have chronic pain and now I'm depressed. I have chronic pain or I have X condition, which is causing the depression. So for example, Cushing's disease, hypothyroidism, multiple sclerosis, stroke, cancers, or certain space occupying lesions in the brain, those would be due to another medical condition. I'm sorry. In children, which is a little bit beyond my scope and the scope of this presentation, is something called disruptive mood dysregulation disorder. It's important to know because it's new for the DSM-5. Okay. Premenstrual dysphoric disorder, that's an important category for menstruating women, and it's very temporally associated with the menstrual cycle. So the onset is the week prior to menses, and then they have a marked affective lability, so mood swings, marked depression, marked anxiety, and then they have a combination. They can have several, combination of anhedonia, difficulty with concentrating, certain cravings for types of food, increased appetite, sleep changes, feeling easily overwhelmed, and then physical changes like bloating or breast tenderness. Those are all associated with premenstrual dysphoric disorder. In an ideal world, to make the diagnoses, they'd have to make a diary and they'd have to track their symptoms along with the menstrual cycle. So that's important to know. And then, yeah, and then I was just coming back temporally, it improves as the menses starts, and then it gets minimal the week after menses. So that's, it's very cyclical that way. Other specified depressive disorders, that is where you're having recurrent but brief depression. So it doesn't meet full criteria for major depressive disorder. For example, it might only be 13 days as opposed to 14 days. So, usually we don't split hairs for a single day, but if it's 5 days as opposed to 14 days, that might be other specified depressive disorder. And then unspecified depressive disorder, that's what we use when we don't have sufficient information to make a diagnosis or confident diagnosis of the other categories. I use this most on the medical floors when I have a patient who's not participating in an interview, when I have just collateral information or review of the medical record or a nursing report, et cetera, to go off of. There's different specifiers that we can use. So if we really want to get specific with the diagnoses, these are the specifiers that are in the DSM-5 as well. Again, I won't go into too much detail, but if you're having features of anxiety, then you can call it with anxious distress. That isn't rising to the level of a full standalone anxiety disorder. So features of anxiety might include feeling keyed up or tense, having difficulty concentrating because of their worry, not because of their lack of motivation and their low mood. Thinking that something awful might happen, losing control, feeling extremely restless. Those are all anxious features. Mixed features are more for bipolar patients or mania, where patients might be having expansive mood, grandiosity, extremely talkative, risk-taking activities, decreased need for sleep. That again isn't rising to the level of a bipolar disorder, standalone bipolar disorder. Melancholic features, that's when somebody has loss of pleasure or lack of reactivity, at least. They need to have either one of those. Plus, they need to have profound despondency, and the depression is worse in the morning, and they have psychomotor changes, lack of appetite, and excessive guilt with melancholic, excuse me. Atypical, they actually have increased appetite, and they have hypersomnia. So that's atypical. And that's important because certain medications are better for atypical, certain medications are better for melancholic based on the research that we have. I'll just say while I'm here, melancholic is better treated with TCAs and atypical is better treated with MAOIs. Psychotic features, they are generally delusions, generally hallucinations, and they can be either mood syntonic or mood dystonic. So either they might hear, if they're feeling negatively, they might hear negative things, whereas they might even sometimes feel negative and then hear things that has nothing to do with how they're feeling. And this is most often reserved for severe depression. So with catatonia, that's a separate disorder. I won't get into too much details about that, but that's waxy flexibility, mutism, echolalia, echopraxia. And then peripartum onset is also important. The DSM-5 doesn't have postpartum depression as a standalone diagnostic entity anymore. So we use this specifier now as if we're talking about patients with pregnancy. And then with pregnancy, so it can happen during pregnancy, can happen after pregnancy, giving birth. So that's why they use the word peripartum. And then with seasonal pattern, it's pretty self-explanatory, especially if you live at this latitude. But with the changes in the seasons, especially the winter, the fall, and the spring are the most common times. So again, important because you might want to use a satellite, for example, for seasonal pattern. Okay, so suicide risk and self-harm. If I could have, feedback from the audience, then I would ask you what the most consistent risk factor is. But it is previous suicide, suicidality, suicide attempts, self-harm. That's the most consistent risk factor. I believe it's 4 times. The odds ratio is for that. Okay. Other features include a patient who's male, so they have a higher risk of successful suicide. Many of you may remember, especially from medical school and maybe even training, where male patients are more likely to commit suicide and females are more likely to attempt suicide. So males are more successful. Patients who are single, living alone, divorced, essentially poor social supports. If they have prominent feelings of hopelessness, that's important. That's an important risk factor, excuse me. Physical illnesses that aren't adequately controlled. If they have borderline personality disorder is also a risk factor. But at the end of the day, sometimes we'll have a patient who we're very convinced, and then on the other hand, a patient that is telling us all the right things. And it's really impossible to predict. So we're trying to look for clues in their history. We're trying to look for clues in collateral information and what they're telling us, how they're presenting on the mental status examination. That's what helps guide us with the recommendations and decision making. The other thing to know is that most suicides are on middle-aged patients. High risk versus low risk. Not going to go over this in too much detail either. However, for your review for posterity's sake, you have this here. Older patients are higher risk. We talked about, so these are all basically opposites of one another. And so, if you have poor insight versus if you have good rapport and you have good social supports, it varies on your risk. Okay. Sleep and depression. I'm running a little bit behind, so I'm going to go a little bit faster now. I'm sorry about that. But sleep disturbances in major depression are related to these abnormalities. And then there is a greater risk of suicide and self-harm in patients who have sleep disturbances, independent of their depression, independent of their mood. What that means is if you've got a patient who says that their depression is okay, they're functioning okay, their appetite's okay, their energy's okay, but their sleep is not good, then that still raises their risk for suicide and self-harm. And serotonin is a kind of a common pathway for both sleep and depression. On polysomnography, slow wave sleep is decreased, slow wave activity is reduced, REM latency and reduced REM latency and increased REM density. And then the first REM sleep, the first cycle of REM sleep is longer in duration for major depression. And then I just wanted to put a little note about restless leg syndrome. Again, I know it's hard to not mention too much without getting sidetracked, but with restless leg syndrome, it's important to know because a lot of our medications, for example, antidepressants, can worsen restless leg syndrome. So therefore, their sleep quality is going to be worse. And mirtazapine out of the antidepressants is likely the worst, probably due to histamine H1 antagonism. And then some of the things we can do to help with that is addressing the iron deficiency. Antipsychotics can also worsen restless legs, and so can lithium. Okay. So a brief note on CBT, specifically for insomnia, CBTI. I just wanted to mention that personally, I prefer to use pharmacotherapy if I can. And I think many of my colleagues are the same, but you should know about the advantages and disadvantages of both. So once you stop taking the medicine, it stops working. That's not so for CBT. So even if you stop engaging with the providers for CBT, the benefits are going to still be longer term. Unfortunately, you do need a patient with higher motivation, and they do have delayed benefits. One of the most common techniques they use is sleep restriction therapy, and so they may experience fatigue earlier on in the course. And then for medications, again, if you stop using it, they don't work. And then many of the medications that we use in psychiatry for sleep, like benzodiazepines, the Z drugs, they do have the potential for dependence and tolerance. And then side effects include sedation, which is what we're using it for. And then long-term use may negatively impact memory. Okay, so how do people develop depression? Some people develop depression, some people don't develop depression. So this figure I thought was really interesting, and just I know some people learn differently and some people see things differently. So just wanted to include a little figure here where depending on your biological factors, your psychosocial factors, and then filtering through like a prism of individual factors, that's what they're trying to show here with the triangle. Depending on all of these and how they affect you, then you may develop. So it helps us say, well, why did one person have major depression? Why do some people have just sadness? And even though they may go through very similar circumstances, they may have similar backgrounds, they may be very similar on the surface, but these are some factors below the surface that helps us explain why we have different outcomes. Okay, so I hope this will be more relevant for most of you, or some of you anyway, that medical illnesses and depression, I hope it's not a big shock, but if you have untreated depression, you're going to have worse physical illnesses. I mean, it really is a bidirectional relationship. So untreated physical illnesses are likely going to worsen your depression. Many physical illnesses are inflammatory in nature, so is depression. How does that affect the patient's care? Well, they're most likely going to be not as motivated for treatment. They're not going to be able to do as much as you think about. And so, what you're recommending, they may not engage in that. it's difficult for I know what the culture is like on the internal medicine side of things, and the surgery side of things. So I know it's for me to sit here as a psychiatrist and say, hey, you need to do this screening questionnaire, and you need to talk about this, and you need to ask about this. That's may not be helpful for many of you, but what it is, the evidence shows that any type of screening, so it doesn't matter which one you do, but if you're going to use a screening questionnaire, you can even use the PHQ-2 instead of the PHQ-9, so 2 questions, but any type is better than nothing. This is the Beck Depression Inventory. This is the Hospital Anxiety Depression Scale, and this is the Montgomery-Åsberg Depression Rating Scale. They're all different. They have different, I'm not going to go into them in too much detail, but you can find them online. Some of them have licenses, some of them don't. The PHQ-9 is free to use. So each have their own advantages and disadvantages. And then there's the other challenge for this idea is that they not only do they have a very similar burden, but they have a very similar overlap in as far as their symptoms go. Okay, a little break for both everybody, for me and you guys. So the nurse says you scored 25 out of 27, probably the PHQ-9 on your mental health questionnaire. So that means I'm good at mental health, right? Crisis counselor enters the room. Beans. I thought I enjoyed that. Okay. So this is, I'm going to spend a few minutes on this slide. And what I'd like to do is draw your attention to different organ systems and how they're affected by depression, or how depression affects them, and also some of our treatments affect them. So we'll start with the heart. And so, coronary artery disease, ischemic heart disease, arrhythmias, higher frequency in patients with depression. And sometimes it can also be underdiagnosed, because after it may be subsyndromal, it can be persistent. Some people may think it's a normal reaction, or I'm supposed to feel this way after a major heart event, for example, or CABG. And so that is something to think about. And then, unfortunately, patients with depression, if a patient has depression, it doubles their risk of subsequent ischemic heart disease, increased ventricular arrhythmias. And then I was reading about this concept of vital exhaustion. And so what that is it's the way of conceptualizing a mental state of unusual fatigue, feelings of dejection or defeat, and increased irritability. And that increases the risk of coronary disease. So patients who have this vital exhaustion, that increases their risk. And then one thing to keep in mind as well is if these patients are being undertreated, the most, again, and we'll talk about this. I'm sorry, I haven't gotten into it yet, but the treatments for depression, SSRIs, can actually help based on their effect on platelets. So they can affect outcomes as well. Not that they're treatments for coronary artery disease or ischemic heart disease. That's not what I'm saying, but I am saying that you might get 2 birds, 1 stone. You might get quite a bit of help. Okay. Asthma and COPD, so respiratory illnesses. Both of these, as you know, are inflammatory illnesses, so they both get worse with depression. Depression worsens both of them as well. And then COPD, they often have a lot of cognitive distortions. CBT has been helpful for this as well. So the other thing to think about with these is the medications we use are corticosteroids for the most part to reduce inflammation. And then low dose chronic corticosteroids may worsen depression, whereas high dose short course steroids can also cause mania or hypomanic symptoms. So something to think about. GI symptoms, sorry about that. So GI symptoms, GERD, gastroparesis, excuse me, again, would get worse. And then some medications like SSRIs may worsen those because of increased vasal tone. Like for TCAs and for SSRIs for GERD, that might be worse. And then lower intestines, lower GI tract for Crohn's and irritable bowel syndrome, irritable bowel disease. That again is a hand in glove relationship. And TCAs actually might be helpful. Low dose TCAs and duloxetine might be helpful for patients with those illnesses. Diabetes, actually, Yeah, so let's talk about end-stage renal disease really quick. There's not a lot of medications that are like, okay, this is the medicine to use for patients with ESRD. So, and part of that might be because it's really a tough illness on patients physically. And so, a lot of the fatigue, if they're on dialysis, a lot of the worry and a lot of the lack of appetite, impaired sleep, the lack of concentration might really, possibly be related to their end-stage renal disease. And also, many of our medications might be removed in dialysis. But if you do have to use one, the idea would be to use sertraline and possibly escitalopram, citalopram, just because it probably have the least amount of potential interactions. If you're going to use TCAs, be aware that patients with ESRD are more likely to be sensitive to their side effects because of the hydroxylated metabolites. Endocrine, so for diabetes, etc. Sorry, not etc. But for diabetes, patients with diabetes have a 2 to 3 times increased incidence of depression, and that is independent of their glycemic control. However, patients with well-controlled depression are more likely to be at target for their glycemic control. And one of the things they developed is a diabetes distress scale. And so that can help determine how much distress you're going through in diabetes. And then also fluoxetine CBT is helpful for that. Other endocrinological issues like thyroiditis, Graves' disease, parathyroid disorder, Hashimoto's, they can all affect the mental state. I don't have too much time, unfortunately, to go into too much detail about those. I'm sorry. But Cushing's disease, you should know, presents very similarly to a major depressive episode. So something to think about. But it's fairly rare, so there's no routine screening that's recommended. But again, if they're treatment resistant, this is all things that you should be, as a provider, should be thinking about. So there's inflammatory illnesses, rheumatoid arthritis, cancers. Those obviously get worse. With cancer, it's different. They're worried about life. They're worried about, they're being demoralized. Some chemotherapeutic agents may worsen mental status. Something to think about. And then hematology, but hematology for iron deficiency, anemia, for example, vitamin B12 deficiency, sickle cell, and then some of our medications also can affect the blood, right? So thrombocytopenia and agranulocytosis, they're rare, but they can happen. Okay, depression and dementia, we have a dearth of many, we have a silver tsunami of elderly patients now. And so the incidence of dementia is likely going to increase before it decreases. And it's hard to diagnose because, again, A, the patient isn't very reliable, or B, it's hard to tell what's dementia, what's depression. So anyways, there's this Cornell scale of depression in dementia, and it is a 19-item scale, and there's a patient and there's a informant or a collateral, basically, portion of it. And it takes about 20 minutes, so more time than most internists have, but it is something to think about. Yeah, a higher score obviously indicates more likely to have depression. A mental status examination, downcast, furrowed brow, report of low mood. And then if you're going to use antidepressants, especially in patients who are agitated with their dementia, the antidepressants have one of the best risk-benefit profiles. So, and citalopram, has good evidence for that. So if they're both having depression and behavioral symptoms like wandering or agitation. Okay, so let's spend some time. Hopefully, I know I always run later than I think I will, so I'm sorry about that. Anyway, so these are the depression treatments we'll be talking about. As an overview, though, this is kind of the categories of treatment. When I'm in my mind, this is what I'm thinking about when I'm thinking about treatment resistance. So because the whole idea of treatment resistance is that one thing isn't going to work. And that's the definition of treatment resistance. Different people define it as different. What is that one thing? So sometimes some sources will say one fair trial dosed well. I think it's 150 milligram TCA or SSRI equivalent, milligram equivalent, is what the dosage should be. And a fair trial, ideally 4 to 6 weeks at the minimum. and most likely, if you're going to see them for treatment resistance as a psychiatrist, especially if I'm going to see them, they've tried multiple medications, they've tried different things. So therefore, we're going to have to approach this in a multimodal manner, just like you would with a chronic pain patient. You're going to have to use different things. Okay. Psychotherapy. This is the only one slide I have on psychotherapy, so it's a busy slide. And the reason I've included it is because many of my allopathic colleagues may not be as familiar with psychotherapy. And so this is just a brief summary of some more types of therapy other than just CBT. So that's, most people are familiar with CBT, and really, even though they might be familiar with it, what is CBT and what do they do and how do they do it? This kind of gives you a little brief overview of that. The downside of therapy, of course, has always been access to the therapist. It's always been attending therapy sessions, and then sometimes cost as well. So those are oftentimes the drawbacks of therapy. And then, patient motivation, essentially. So severe depression may not always be possible. Now with the pandemic, there are more online options. There's apps that are available, which make some of these things more accessible to patients, which is a positive. Okay. No discussion of depression treatments and medications complete without STAR-D. I won't spend too much time, but essentially big study, a lot of different sites, different treatment levels, not double-blinded, and patients were able to choose their own treatment course with their providers at all these different treatment sites. First level was citalopram. Second level was adding bupropion or buspirone to citalopram, or then switching to CBT completely, or adding on CBT, or then switching to sertraline, bupropion, venlafaxine, and then as level 3, I'll just go over really quick. But level 3 was adding lithium or cytomel T3 triiodothyronine, or then switching to mirtazapine or nortriptyline. And then finally, level 4 was switching to tranylcypromine or Parnate, which is a monoamine oxidase inhibitor, or venlafaxine XR plus mirtazapine. So both of those are dual acting agents, and so having both of those at the same time. It was promising. So the patients, did get better over. And then the thing was that, as you went through a single level, the patients who got better didn't go on to the next level. So it was only the patients who weren't getting better would then go on to the next level. Okay. So that's the STAR-D. It's very important to know about that because we use that in psychiatry quite a bit to talk to our patients about medications. Common side effects, drowsiness with all psychotropic medications, GI side effects, weight gain, arrhythmias, cardiac side effects, sexual dysfunction, intimacy related issues, sweating, sugar cravings, weight gain, appetite, and then tremors. So those are all common side effects. I'm going to spend some time talking now about medications, the next 4 slides or so, and then we'll talk about toxicity and side effects. And then we'll talk about interventional psychiatric treatments. So SSRIs include, most people are familiar with them, but the pathognomonic one, Prozac or fluoxetine, is really the one. If you're ever trying to remember what is an SSRI or what does an SSRI look like, that's an SSRI. And I like Prozac. I use it quite a bit. It's helpful for a lot of different disorders. It's helpful for young patients. It's weight neutral, so that's helpful. It's more stimulating than sedating. So if patients are having, sort of neurovegetative symptoms, it can be helpful for that as well. And then paroxetine, I don't use a whole lot of paroxetine, but it has its place in treatment. But it is a little bit different. It's a little bit more sedating, and then it does have some more withdrawal symptoms. SNRIs, so SSRIs are selective serotonin reuptake inhibitors, and then SNRIs they're serotonin norepinephrine reuptake inhibitors. And so what's happening is that you're increasing the biogenic amines in the synaptic cleft between neurons in the brain. The level of those neurotransmitters is going up. And the reason these are targets of treatment is because patients with suicide and depression on autopsy, their cerebrospinal fluids were found to have low levels of serotonin. So here we are. Okay, lower doses, similar side effects to the SSRIs, and then the higher doses, you're getting more of the norepinephrine piece, so you're getting more of the sweating and palpitation as far as side effects go. And then venlafaxine, important to know, hypertension is unfortunately a problem at higher doses. And then duloxetine or Cymbalta, I'm sure most people know neuropathic pain, and if you've diabetes or any type of pain, really, people are using duloxetine. But that is more at the higher doses, so 90 to 120 milligrams. Okay. So the next slide has three classes of medications: norepinephrine and dopamine, and that's going to be your bupropion or Wellbutrin is the brand name. This is the generic name. 450 milligrams is generally the maximum dose. These are the common side effects. A lot of patients appreciate that they don't have any weight gain or sedation with this medication. I still don't use it as a first line. However, I will add it onto an SSRI. It is also one of the strategies that's suggested to counteract some of the sexual side effects associated with the SSRIs and SNRIs, which can be as high as 30%, sometimes even higher. All right, noradrenaline blockers, alpha-2 antagonist, excuse me, is mirtazapine, or Remeron is the other name of that. It does have its place in treatment. It's quite a helpful agent. It increases, eventually downstream effects are to increase serotonin, but it doesn't have the same sexual side effects as the SSRIs. And then serotonin 1A partial agonist. This is buspirone or buspirone, also known as Buspar. The reason I've included it here is because it was one of the adjunct medications that they used in the STAR-D trial. And it is fairly well tolerated. It's helpful for patients with concurrent anxiety and depression. The downside of it is that it's only 2 or 3 hours half-life. So you need to dose it several times a day. Otherwise, they may not get the full benefit of it, and they need to wait a while. The other thing you should know about Buspar is, according to Micromedex, the milligram for milligram effectiveness of Buspar is the same as Valium. So it is effective. In my experience, patients who have used benzodiazepines will not think that Buspar is helping them for their anxiety, unfortunately. Okay, so tricyclic antidepressants, they have quite a bit of sedation. They've fallen out of favor. They're a little bit of having a resurgence, I think, right now. But from a depression standpoint, we don't use a whole lot of them simply because of the side effect profile and also overdose profile. Clomipramine, usually used in OCD, and it is quite effective in helping with that. But unfortunately, if you stop them, and especially with amitriptyline, you can have high discontinuation. It's a little bit less with nortriptyline, but it can still happen. The benefit from a treatment point of view for TCAs is you can check their serum levels. So for patients who are worried about their with treatment, if they're not taking their medications and you want to check, that might be one way to do that as well, if you need to. But there's therapeutic ranges, so you can see if they're in toxic ranges and whatnot, therapeutic indexes. Dopamine partial agonists, D2, and also has partial 5-HT serotonin 1A agonism, and also a blockade of serotonin 2C and 7 receptors. That's aripiprazole or Abilify. It's a second generation antipsychotic, and it is used and it's actually approved as an adjunct for depression, lower doses than we would use for antipsychosis, as an antipsychotic or mood stabilizing. It's important, it's metabolized by 2D6 and 3A4, and so there is an interaction with Prozac, which is an inhibitor. Okay, synthetic hormones, the really only one we need to talk about is Cytomel or triiodothyronine. Again, it was used as an adjunctive treatment in the STAR-D trial, and it can be used up to 50 micrograms a day. And we think it works, it helps them work better, and fairly well tolerated. But one of the things you might want to do is monitor their thyroid function with that. These are newer antidepressants. Personally, I don't use a ton of these as a psychiatrist myself. But you may use them, and you may come across them. You may see patients with them. The reason I don't use a whole lot of these, especially these first four, is just because I don't see a whole lot of benefit compared to ones that are already on the market. But if patients are interested in trying them, and we'll talk about genetic testing at the end, but if they're interested in trying them or if they think that they'll tolerate these better, then I give it a shot. I do like fluvoxamine or Luvox for OCD as opposed to clomipramine. It's an SSRI, so its side effect profile is a little bit more favorable. Vortioxetine, it's a multimodal antidepressant, so it works on quite a few receptors, and it's approved for major depressive disorder up to 20 milligrams a day. Vibrate or vilazodone is another newer antidepressant, and that's up to 40 milligrams a day, slightly quicker onset of action. This is an interesting antidepressant. This is, I think, the newest antidepressant as far as I know. It was approved last year in 2022. It's called Auvelity. The other name for it, or the generic, it's a combination of bupropion and dextromethorphan. And so it does what bupropion does, as we talked about on the previous slide, but with the dextromethorphan addition, it also does the NMDA antagonism and sigma-1 agonist. And then, and the reason they've added, I think the reason they've added this is because of the CYP2D6 inhibition for the bupropion, which then results in less metabolism of the dextromethorphan, so higher available dextromethorphan. And it does work quicker than other antidepressants. Okay, I need to take a break again. I don't like myself. That's very common. Really? Oh yeah, loads of people don't like you. Okay. So when we're using these medications, as we've mentioned in treatment resistance, we may need to use higher doses. We may need to use multiple medications, and we may need to use even two or three medications. Is not uncommon to see patients for their depression. So these are some of the downsides of using them, and some things you should be aware of. So serotonin syndrome is when we have an excess amount of serotonin in the GI tract and in the brain, in the CNS, and that causes a variety of symptoms, but really a lot of delirium, fever, hyperthermia, autonomic instability, and then the one that always they have on our boards exams is diarrhea or GI changes. The reason they have that is because there's a lot of crossover with NMS or neuroleptic malignant syndrome. And so both of them, so you might have a patient who's taking an antipsychotic. They might be taking Abilify, for example, or Seroquel or quetiapine, for example. And then they might be also taking 2 or 3 antidepressants with buspirone, and then they're coming in with these symptoms. They look like delirium, confusion, and they have rigidity. And then they might even have elevated CPK. CPK is usually with NMS, neuroleptic malignant syndrome, but it's hard to tease it out. And so anyways, GI changes and diarrhea. And that's because of the bulk of the serotonin receptors are in our GI tract. SIADH, which stands for the syndrome of inappropriate antidiuretic hormone. And so what happens is the kidneys are absorbing too much water. And so therefore the serum sodium levels are going down. So they have hyponatremia. And that's usually a concern for elderly patients. That's a risk factor. Patients who are female, and then patients who have a lower level of sodium to start with, a baseline sodium, that's a risk factor. In addition to patients who are taking thiazide diuretics, that's something to keep in mind. Discontinuation syndrome is also important to think about when we're using these psychotropics. So it'd be nice to say, okay, yeah, you're taking this med. Okay, now stop taking this med, take this med. So sometimes it can be a little bit tricky, especially as I mentioned with the SNRIs like venlafaxine and duloxetine and paroxetine as an SSRI. You want to do a gradual taper. Sometimes it might be so bad that you might need to use fluoxetine as a bridge, because fluoxetine has a very long half-life. And so most times they'll have it as a flu-like illness. They might experience zaps and kind of pins and needles tingling in their fingertips. Those are all discontinuation syndrome. EPS or extrapyramidal symptoms are less likely to occur with antidepressants, but as I mentioned, if you're going to be using antipsychotics, then that's something to keep in mind. And that's when you have dopamine depletion. Usually happens over time, but it can happen acutely. It's called acute dystonia. But if what happens over time, it's called tardive dyskinesia. You've likely heard of it. And that's grimacing of the face, the mouth. They have lip smacking. Their eyebrows are going up. They might have neck rolling, and it's called torticollis, things like that. Okay, and then QT prolongation, more commonly associated with the antipsychotics, but it can happen. Thioridazine, which is a first-generation antipsychotic, is the highest amount. something to think about if you're working in different settings. For example, in the ICU, if you're working in hospital medicine, you need to be aware of different routes of administration, maybe not relevant for most of you, but one thing I want to mention for this is Prozac or fluoxetine is one of the only antidepressants. In fact, I think the only antidepressant that I'm aware of that has a once weekly formulation. So I mentioned the long half-life, and that's because, and so we can dose it at a 90 milligram capsule. I don't know about insurance coverage and all that sort of thing, but it is available. And then, that they just have to take that once a week. So 4 times a month, which is kind of convenient for some patients. Okay, next slide is ketamine, and that is a dissociative anesthetic. It is beneficial for depression at low levels. We use it at low dosages. We start off at 0.5 milligrams per kilogram when we're dosing it in the IV form. And again, that is an off-label indication. It is a rapid antidepressant, so it works quickly, but then it's transient. So that's why patients have to come back for repeated infusions, ketamine infusions. And they have, I'm sure wherever you live, they have some ketamine clinics. We had some in North Dakota, so I'm sure you have them in Houston and California and the East Coast. If you're going to be recommending them to your patients, see if they're run by a mental health team, just because a lot of CRNAs have been using and setting ketamine clinics. I'm not bashing CRNAs. I'm not saying they're not doing a good job, but it might be an idea to have, especially if you're going for mental illness related reasons, to have a specialist involved. Ketamine can improve suicidal thoughts. That's very, very promising. There is different formulations. There's 3 different formulations of ketamine. There's an IV formulation, which I've already talked about. There's an IM formulation, an intramuscular injection, and then there's a nasal spray, and that's called S-ketamine or Spravato. And that is actually approved for treatment-resistant depression as long as they're taking an oral antidepressant. It doesn't matter which one, it doesn't matter which dose, it just matters that they're taking both. Okay, and then the side effects for all forms of ketamine are this kind of this strange feeling, this wooziness, almost like an out-of-body experience, and then visual distortions, numbness, and then it can even sometimes feel, it can be pretty bad, it can sinking into a hole. One of the contraindications I should mention as well for ketamine is active psychosis. So that's something, because it can get worse with ketamine use. While they're getting the infusion, they can have transient hypertension. They can have increased increased heart rates or tachycardia, and then dry mouth, blurred vision. Majority of that gets better in the first 30 minutes. It's almost always resolved within the first 4 hours after the infusion. Okay, this is a flow chart. I won't go into too much details on this, but this is the website that's available at. They do have different algorithms for other psychiatric illnesses, anxiety, I think OCD, I believe schizophrenia, and I believe bipolar disorder as well. And so they have different algorithms. So this is a summary of that algorithm. It's in a different format than what they have, but essentially, if it's severe depression, you can go right to ECT. If not, then you can try antidepressants. You might want to switch among them. You can add another one. If TMS, I'll talk about that in a minute, if that's an option. You can also add these. I didn't really talk about these, but these are herbal over-the-counter preparations that are available that may be helpful as well. It's important to know about serotonin syndrome risk with St. John's wort. Nutrients, light therapy can be added on. Second generation antipsychotic, i.e. Abilify, i.e. quetiapine, may be helpful. Bupropion or imipramine, lithium, T3 are also options. If all that is failing, then maybe a time. And you may, and I sometimes get the question from my internal medicine colleagues, Dr. saying, well, when should we refer to you? When do you want to see these patients? What is too early? What is too late? And so it's a fine balance, because on one hand, I don't want patients who have tried every single drug and then we don't have any options. On the other hand, I don't want a patient who's only tried one drug with some benefit. So, or sometimes I'll have a patient who they started Prozac yesterday or last week, and then they've already scheduled to see me, and so that's not always helpful. But it's completely provider and patient dependent. Okay, ECT. You've likely heard of it. It stands for electroconvulsive therapy. And so what we're doing is we're inducing a seizure, a convulsion, with the use of electricity. And it is helpful, it's beneficial, it's often reserved for the most severely depressed patients. The reason for that is it's hard to do, practically speaking. It's a hospital procedure, there's anesthesia involved, and then there's a recovery period involved, there's a workup involved. So it's really reserved for our most depressed patients, and even in those patients, it's quite effective. Okay, I'll just some history about it here, and then this is how we think it works. All the neurons are always firing at different rates and different sort of directions, I guess. But if you kind of line them up and you send an electrical signal, then what we think is they have synchronous neuronal firing and increased permeability of the blood-brain barrier. We think it also increases neuroplasticity. We think it also increases BDNF, or brain-derived neurotropic factor. Importantly, there are no absolute contraindications to ECT. So some patients will, some providers or patients will say, I have seizure disorder, I have a brain lesion, or I have, this, but there's no absolute contraindications. It's a risk versus benefit question at all times. Usually it's given 2 or 3 times a week. Generally, we aim for about 6 to 12 sessions. And then risk-wise, it's fairly benign. I mean, not benign, of course, but it is not a very risky procedure. General anesthesia and childbirth is comparable risks. Most common side effects are memory, especially during the treatment episodes, during these sessions. And during that time, like let's say it's going to take 2 weeks or 3 weeks, that time for a patient is a little bit fuzzy. And then muscle soreness, because depending on the anesthesia, they may not have an adequate, muscle paralysis. This is an image I found for a patient that's about to receive ECT. This is what it looks like. These are the leads on the brain that are measuring the EEG. And then these are the paddles. These are the electric paddles. There's usually a button on the side that you press, which delivers the electric shock. Ideally, we'd like to see a seizure for at least 30 seconds for it to be considered a successful treatment. And then there is a titration sort of protocol that you go up. But again, that's, I think, beyond the scope. Okay, so TMS is transcranial magnetic stimulation. And what that is it's used, and it's FDA approved. It's a little bit less intensive. So it may be more helpful for patients with moderate to severe depression as opposed to just severe depression. But it is an office-based procedure. We do this here at the clinic here in Minneapolis. And there's a technician, a TMS technician, who does the actual procedure. This is the machine. And then what you hear, the reason this patient has some earbuds put in is that you hear this clicking sound. It's not too loud, but I mean, I wouldn't want it too close to my ears or my head either. Okay, the mechanism is rapidly changing magnetic fields. Small electrical currents are induced. And then those are that coil that is on the head here. That's what's inducing the magnetic fields. And then because of that, we can kind of target smaller areas of the brain. But for depression, it's the left dorsolateral prefrontal cortex that's targeted. There's different protocols. It is a little bit more long-term and a little bit more of a time commitment. But there is the same protocol now that's developed that's trying to do it once in 1 week. I haven't actually met anybody or even a TMS technician that's done it at our clinic, but I think in South Dakota, they were trying to do it, but you need quite a bit of commitment from the patient, to go in for a week, and then they're there basically the whole day just getting TMS. Fairly well tolerated, but the most adverse effect is seizure. Okay, I'm not going to spend too much time on vagal nerve stimulation, but it is something that may be possible. Here they defined treatment resistance as 4 or more antidepressants. So again, not a first-line treatment. And that was developed since July 2005. This was from this source here, but essentially it's a neural circuitry of depression by stimulating vagal afferent fibers in the neck. And then that targets the brain stem, the locus coeruleus, and dorsal raphe nucleus. It helps in drug-resistant epileptic patients. So it can, it's one of the indications for VNS as well. And then some of the downsides are, because it is a surgical procedure, I'm sorry, I didn't go into too much detail about it, but essentially what you're doing is you're implanting a device that attaches to the vagal nerve. The vagal nerve is a cranial nerve. It's the longest cranial nerve. And you have two vagal nerves, one on this side, one on this side. And then this attaches to the vagal nerve here. And then they basically run a wire down, and then they implant the device here on your chest. Many patients and providers always ask about genetic testing and screening. There's one company that's quite well known. It's called GeneSight testing. And so I've used it myself for patients. I haven't recommended it. It's usually the patients who ask to have it done. And again, that's in patients who are treatment resistant, who have tried multiple medications, who have have different trials, and they're tired of being sort of treated like a guinea pig, that they don't want to try another medicine and then fail or have side effects. So the way it works is essentially they're taking a swab, usually it's a cheek swab, and it helps us determine what their CYP450, and then it helps us predict how the medications might be metabolized. So if they're rapid metabolizers, for example, we might need to use higher doses, etc. It's not really that helpful. It's more reassuring for patients and sometimes providers as well. Okay, pretty much close to being done. I'm sorry if I'm running behind, and I'm sorry if somebody had to leave, but these are some of the take-home ideas. Depression is prevalent. Treatment resistant is prevalent as well. But it is treatable. We do have options. That's good, especially with ketamine now, with TMS. Those are all helpful things. In treatment resistant, we're likely going to need multiple modalities. So likely one thing just by itself isn't going to be helpful. Therapy by itself isn't going to be helpful. Medications by themselves aren't going to be helpful. If you're worried about acute risk, you may need to be considering hospitalization. If they have a plan to hurt themselves, if they have access to means, especially firearms, that raises their risk quite a bit. Robust overlap with a lot of medical illnesses. I hope you got something from that, but different medical illnesses. And then every patient that you think has depression or struggling with depression, please ask them about self-harm and suicide. I promise you, you're not going to make them worse. Some people think, well, if I bring it up, they're going to start thinking about it, or going to think, oh, it's okay to think about it or okay to do it because a doctor asked me. That's not true. They'll likely appreciate you asking about it. They'll likely want to talk to you about it. So please ask them about it. And it's probably going to be on Friday afternoon, their last patient of the day. So, but that's the way it is. If you don't mind scanning this QR code, if you had a good experience, then fill out the survey. If you didn't have a good experience, don't fill out the survey. And no, that's a joke. And then if you have any questions or comments, please feel free to ask. You can also enter them on the YouTube chat. If you're not comfortable doing that and you need to contact me afterwards, please feel free to do that as well. Thank you.
Shukran, Dr. Abdul-Hussein, for that wonderful talk and discussion on the more challenging aspects of managing depression in our patients. Honestly, even as a primary care physician, this was very helpful. It helped me gain a better understanding of some of the management techniques. Many times patients will come to us after having discussed the options with their psychiatrist or specialists, and they want our opinion about it. And we sometimes don't really know much about it. So this is very helpful. We can actually have a meaningful discussion this time. So thank you. We have a few questions that have come through. One of them has to do more with depression. So eating disorders, you had mentioned, or I had mentioned in the bio, that you have a history of working with an eating disorder clinic and in an inpatient setting. So one of them is, we're seeing a perceived uptick in eating disorders in our community. Can you talk about the overlap of eating disorders with depression and the possible causes for this increase?
Yeah, so I'd be reluctant to comment specifically on our community or anything, different like that. But the only thing I can speak about is from my experience with treating both. The eating disorders, unfortunately, especially if they're severe eating disorders, enduring eating disorders, they don't have a good medication treatment base. We use medications like we would in other patients with concurrent illnesses. So many patients, unfortunately, most of them are female patients who are in the inpatient units. They have a history of trauma and they have PTSD. So we would treat the PTSD separately, just like we would in any other PTSD patient. The mainstay for treatment for eating disorders, especially inpatient, of course, is refeeding. That's where their focus is on, and a lot of that is therapy. And so they have groups because unfortunately the eating disorders is a body perception illness. So they are perceiving themselves as overweight when obviously the reality is that they're quite a bit underweight. And so there's no medicine that can work on improving your perception. And so that's more of a therapeutic intervention. So I guess as far as uptake goes, I'm not sure what would be explaining the uptake. Yeah.
Thank you. Can you comment? Here's another question. This deals with adjuncts for the treatment. Can you comment on mobile apps as adjuncts for treatment? Any particular ones you would recommend for depression?
Yeah. So I don't have any. I'll approach it. I'll answer that how I would if one of my patients asked me. So I would tell them that if there are apps that are helpful, I would encourage them to try it out. And I would encourage them to try to read the terms and conditions. The reason for that is because as a practitioner, I don't want to be in a position to recommend any certain app. The reasoning for that is because I don't know how their data is being used. I don't know how secure it is, etc. I don't know if it's being sold, whatever. So and different patients have different challenges. So if it's sometimes there's a mood tracking app, sometimes there's a reminder app, sometimes there's a diary app. And so those types of things are helpful. And also I tell them they use an app if you're comfortable using it for tracking treatment as well. So like you come to see me for initial evaluation, how are you feeling today? It's important to track that and make a note of that. And then over time, let's see how you're going to be feeling. Hopefully you're going to be feeling better over time.
Okay, it's interesting.
Answered like a true psychiatrist, right?
Actually, it's true. There's quite a bit of the tracking, and then they just loop themselves into the same depressive exposures. So
yeah, and so I tell them, I don't have a specific app that I would say this one's better than that one. I personally, I haven't tried them. I have patients who come in and show me that this is what the app they're using and this is what it does for them. So that's, that's up to them. I never say, well, don't use this app or use this app. No, that's a very personal decision for them. Some of them are paid, some of them are free. That comes with different, issues itself. Some of them have artificial intelligence built in, some of them don't. So.
Right. Here's another one. Ketamine effects appear to be similar to cannabis use with some of the dissociative symptoms. For those who may be self-medicating, is there any research to support THC or CBD use for depression?
I haven't looked this up recently, and I'll be honest about that. Last I heard, there wasn't any, there's no randomized double-blind control, placebo-controlled trials that have THC over medications or placebo. Anecdotally, of course, I've met many patients who tell me it helps them with not so much with depression. I will be honest about that though, more for anxiety. So many of my patients, especially with PTSD, and I remember working at the VA, and that's one of the things they would always tell me is the first thing they would tell me is, Doc, my marijuana is helping me, and I really want my marijuana. And so so that was something I remember. But so yeah, well, can you repeat the last part of the question one more time?
Oh, is there any research to support THC or
Yeah,
CBD?
I wouldn't say that, and I always tell my patients it has nothing to do with the legality because that's what they think it is. They think I'm worried about the legal issues and the implications. It's nothing to do. I was the same recommendation when it was legal or illegal or recreational use or medicinal use. It was the same thing that I had. But
All right, wonderful. That I think for time's sake, we'll stop there. If the audience has any additional questions, Dr. Abdul Hussain has given his contact information. Also, just wanted to end with Sajadat and Shukriya upon Sagla Maulana Gulamo and Bandiyo Che. And as clinicians, we strive to serve our community and our Mola, and we do dua that we can continue in our service with Josh and humility. Thank you again, Dr. Abdul Hussain, for your time and effort you put into preparing for this presentation. And we can combine do dua ke hamara Mola, Aqa ne Mola, ni Umar Sharif ne, ta roz Qayamat, daraz ne daraz thai. Thank you all for attending this webinar.
Thank you. Good afternoon, Sagla.